Wednesday at 4:30. Welcome to the weekly Gecko session hosted by the Gastro Foundation of Sub-Saharan Africa in association with Project ECHO at the University of New Mexico. Today we have 59 registrations from 10 countries. And it's a great pleasure to welcome Sandie Thomson, who needs no introduction and who will devote the session to what to do with a large bowel bleed, and if there is time, there's a case presentation that he will add. So welcome, Sandie.
Thanks very much, Chris. I'm going to share my screen and go ahead with the talk. Please just let me know if you can see it.
It's not in presentation mode, Sandie. Just swap your displays.
Okay, thank you. Okay.
Okay, all good.
Thanks very much. So my task today is to talk about lower GI bleeding. And obviously, this is really something that is not nearly as common as upper GI bleeding. And normally, it's something that is low on the register of acute emergencies, but it definitely falls into that category. I'd like to start by just talking about the best data that I think is around on lower gastrointestinal bleeding. And that's UK data from some time back when they did a 2-month or 3-month survey of 143 NHS hospitals, comprising 2,528 patients who were admitted, who were inpatients with lower GI bleeds during that time. And I'm just going to show some simple data from that that helps to sort of give some perspective on the condition and exactly what happens to it in the general run of things in the UK, and I think very much so in other places as well. So if you look at it, you can see the number of 2,500 there at the top. And you can see that most of these patients are having a flexible sigmoidoscopy. A significant number of them, about 10%, have a upper endoscopy at some stage, either before or after the flexible sigmoidoscopy. And you can see only 4% had colonoscopy, and then another similar volume had rigid sigmoidoscopy, showing that some of these patients are presenting to the old-fashioned general surgeon who still uses the rigid instrument. And when you come down to those who require hemostasis, which is what I'm going to talk about a little bit later, is that again is just 2% of this number of 2,500. So I think it does put it into perspective and puts it into perspective in relationship to upper GI bleeding. You can see here I've put forward from the same series exactly those people who might be considered by some to have at least significant bleeding. And I've highlighted those that have more than 4 units, and you can see that's about 10%. And those who have had a CTA, which is a computerized angiography. And we'll come back to that in a minute, but you can see that that's only 6% of this total. And I'll discuss a little bit more about the recommendations in a minute. But you can see these are the ones that actually had some intervention. So either endoscopic therapy, embolization, or laparotomy. And you can see, apart from hemorrhoids, the most common causes that are here are diverticular disease and angiodysplasia. But again, when you look at the big number, this is a very small number. And obviously, individual hospitals are seeing small numbers of these every year. They're really not common occurrences at all, especially in interventions to deal with the bleeding, because the majority of the bleeds are self-limiting. And again, you can see that a few go to laparotomy and some go for embolization. And you can see that the other facts from this are that 48% had no inpatient investigation. And I've used the surrogates for severity as the CTA, which is 6%, and the transfusion of more than 4 units, which is about 10%. So that's the number that we consider have significant GI bleeding from the lower gastrointestinal tract. And if you express this in a different way, in a graph that sort of represents the sort of percentages, you can actually see the fact that 68% had no adverse outcome. And again, there are transfusions, which again is obviously something that is a marker of severity, but it doesn't necessarily translate into other adverse events. And you can see the small amount that had therapy. So with this large number, what has happened is that a lady called Oakland, who, if you look at lower GI bleeding, you'll see her all over the literature in various guises. But she is actually a surgeon, and she looked at this across a variety of different aspects. And she came up with this score. We've all seen upper GI bleeding scores. And in fact, many of the upper GI bleeding scores are used to evaluate lower GI bleeding. And these are very similar, if you look at them, to the so-called Blatchford, Glasgow Blatchford score. And they're based on 7 variables: age, gender, prior lower gastrointestinal bleed, what you find when you actually stick your finger in the rectum, whether you find fresh blood or blood at all. And then, as usual, we have the characteristics of the heart rate, the systolic blood pressure, and the hemoglobin. It's easy to calculate, and as I'll show you, these are the variables that you can see how they're scored. And you will see that the hemoglobin is differentially weighted depending on the level of hemoglobin. So basically, you're making your points, the majority of your points are based on the hemoglobin, which is not so. And obviously, there's significant points on offer for shock and heart rate. Interestingly enough, high BP still gets a low score in the scheme of things. And the essence of these, like the Blatchford score, are that they predict who it's safe not to admit. Unfortunately, these scores, as in upper GI bleeding, are not so good at determining some of the aspects or the hard endpoints that result in death or rebleeding. So they're not really used to triage to the same extent. And she did a very nice comparative study looking at all the other risk assessment tools that are commonly in place and used for upper GI bleeding and are applied to lower GI bleeding. And again, they are not so good at predicting with any degree of sensitivity or specificity mortality, rebleeding, or transfusion need. So they are in some ways disappointing, but again, we can triage the patients effectively, which is a useful tool. I'm just going to talk a little bit about the diagnosis and management of acute lower GI bleeding in terms of the ESG guidelines. And you'll see there are a few famous folk sitting around in these guidelines, as there always are. And I've sort of met one or two, in particular Ian Graniak. And I just want to sort of briefly take you through them because they're really simple, but they really do give you what we should be doing with the patients. And again, you do, as I said, the bleeding severity assessment. We've discussed the elements of that are in the score. And then you categorize the patients into hemodynamically unstable or hemodynamically stable. And the approach is different. Again, we do want to take a decent history around it. Is this the first bleeding episode? Have they had a recent upper endoscopy? Have you excluded that there's not an upper GI source? Is this their first episode? Do they have hematochezia or is it melena? And it's very important these days to find out what concomitant medications they're on in relationship to non-steroidals, antiplatelet agents, and anticoagulants. And again, also slipping in here will be patients who have got chronic liver disease, who again will have that coagulation problem, which again can result in unmasking of occult lesions that may be present in the GI tract. And then again, you can look at, it's very important to note whether they've been transfused before or not. So the first thing that you do in the unstable really is that the whole emphasis has changed towards not trying to do emergency colonoscopy or emergency upper GI scopes. It's to do a CTA before any treatment. And again, we've talked about upper gastrointestinal endoscopy. And you should reserve emergency laparotomy for failure of these endoscopy or radiology to locate the bleeding site. Actually, if you're considering it, that's one of the beauties of both methods, both endoscopy and radiology. They may be able to treat the source of bleeding, but they should help you to localize it so that you have to do a lesser operation if you ever have to operate. And then obviously you have the therapeutic options with transcatheter embolization. Again, the beauty about these is that the catheter embolization and the CTA don't require bowel preparation for you to enact the treatment. And again, we've just re-emphasizing it here. CTA is preferred over colonoscopy in unstable patients as it can localize the bleeding point anywhere in the GI tract, and there is no requirement for bowel preparation. And certainly there are some lesions which, irrespective of whether the patient is bleeding or not, will become evident on CTA. Remember, it will give you some degree of standard CT information as well as arterial information. So it's a very useful information and investigation, and it's the investigation of choice in people who are seriously bleeding and unstable. Again, the whole emphasis is that you do not really want to take these individuals to exploratory laparotomy. About half of them will die, and they may, because majority of them that are going that route have got serious comorbidities as well as their blood loss. So again, one should try and make efforts to localize the bleeding before going to surgery, if it's at all possible. And again, as I've said before, if you localize the bleeding site, then you can obviously do a lesser surgical procedure if you're sure where the bleeding site is from. Interestingly enough, these guidelines don't mention radioisotope scanning in any shape or form. And the logistics of that are just generally not practical for managing people with significant lower GI bleeding. So I think it's really out of most people's armamentarium now. Again, if they're stable, again, you can see these guidelines for transfusion and target transfusions are coming from upper GI and from general considerations that in the absence of shock, you really shouldn't be transfusing as much blood. And again, that's a subject, you can see that 10% received over 4 units, and probably if they were strictly managed according to these target criteria, those numbers would be less. Again, that's a very individualized prescription of transfusion. And then you should consider colonoscopy in this group as the first modality of choice. And you may want to prepare them with a rather hefty dose of PEG-based solution, because you really do need to get all the poop out of there, because you've got enough problems coping with the blood obscuring the view. And again, you can see there are different ways of sort of attacking that in an aggressive manner if the patient is an inpatient, even using a nasogastric tube to deliver it in some of the frailer patients if you deem it necessary. And then these are the treatment options you can see for diverticular disease, angiodysplasia. And I won't talk about post-polypectomy bleeding because Adam Butov dealt with this quite extensively when he talked recently in this forum. And again, hemostatic topical agents, I'll come to a little information that I have in respect to those items. So, as I said, back to the endoscopy story, unless CTA has already been performed and shows a definitive bleeding source in the lower GI tract, OGD should be performed. So just keep that in the back of your mind and always think about that, especially when the patient presents with melena. Colonoscopy should be the first diagnostic modality in all hemodynamically stable patients, primarily because it offers you therapeutic options. So there's a lot of hoo-ha about when you should try and do these colonoscopes. But the bottom line is that you should do it during the admission when the patient is suitably prepared. And there is no evidence that trying to do it in the first 24 hours or even sooner influences the outcome for the patient. So again, remember, it's CTA to control that type of bleeding and localize it. Then you're into the colonoscopy aspect of it. And remember, the majority of them are still going to remain hemodynamically stable once they're resuscitated. So bear that in mind. So what are the take-home messages from this? You should be at the point of initial assessment using a risk score to identify and triage the low-risk patients so you can manage them as an outpatient basis or with a minimal stay. And again, if these have got outlet bleeding, which is hemorrhoidal in nature, you can manage these patients safely as an outpatient. Remember, even old people, though, with hemorrhoids, especially if they've got chronic liver disease, can bleed significantly from their piles and even make themselves shocked. Unstable patients should be offered CTA to localize the bleeding source. And again, then you can move on to direct angiography to embolize the source if it's feasible. Offer colonoscopy to treat the bleeding and consider embolization if the bleeding is brisk or ongoing or there's failed endotherapy. Again, these decisions are going to be individualized for the patient. So what comes after that? Well, what's in the toolbox to deal with these patients? And I'll just go through that in a little detail. So in the toolbox, first up is that you need a straight scope if you're going to do anything therapeutic in the colon. So you really want to have a good skill set in terms of getting it out because you're going to have blood around. The pictures I will show you are all neat and tidy because they've been edited. But in reality, this is not generally a very nice scope to do in terms of aesthetically pleasing with a virgin clean colon. Then the other thing you need is a water irrigation pump, and you need to make sure that your windscreen wipers are working because you need to get rid of the muck in front of you and also to irrigate any bleeding source that you identify so that you can see to localize for your endotherapy. So those two bits of kit are important. This is a typical angiodysplasia. And of course, you may see these not infrequently. The problem is that they're not all that often are they bleeding. And sometimes they're multiple and you never know what their significance is. But generally speaking, in someone whom you don't find anything else, you would see and manage this. And the way to manage it, as you can see just sneaking in the bottom corner there, is with APC. And there are a variety of different catheters that you can use. And again, you must be careful because when you do use argon plasma coagulation, you do put in quite a lot of gas, and you need to take that gas out periodically and not get carried away, especially if you're doing multiple interventions. So remember, if you're trying to deal with a lot of angiodysplastic lesions, just remember that you do have to remove the gas because it accumulates at a very high rate. These are sort of different examples of the catheters that I've told you, out the end, out the side, and the one that I prefer, which is the C probe. But again, it's horses for courses, and many people prefer the direct probe for dealing with angiodysplasia. Here's a diverticular anatomy. Again, you can see that the muscle is lacking in the diverticulum, and that's where the bleeding vessels are most vulnerable, either in the base of the diverticulum or at the sidewall of the diverticulum. And again, some of these are usually for bleeding, we usually say, these are wide necked, so often you can get a view inside them, but they can be narrow necked, and the narrow necked ones traditionally are associated with inflammation. So that's what it looks like. And that's a clot coming out of one. Now, the bottom line with most of these things is often all you see is altered blood and some fresh blood, but you cannot actually identify the source. But you should be able to get a handle on where the blood is coming from the nearer you get to it. And obviously, if you get to colon above the bleeding, you will find no blood. And that in itself is a valuable finding if you have to go to surgery as a result of ongoing bleeding that you can't localize. You at least can localize it to the segment. Again, here you can see the clot's been removed, and there's a visible vessel in the base of the diverticulum. And you can have a go at it with monopolar hemostatic graspers. Try not to use bipolar, because bipolar creates more energy, and the energy here is dissipated between the graspers. So monopolar hemostatic graspers are very good items to have for all forms of hemostasis, because they're pretty safe and they reduce the perforation risk. So you should have one of these in your toolbox. Ideally, if you're going to use clips in the colon, it's actually better if you can to use a short cap. There are a few of these around. So if you know you're going there to try and deal with bleeding, put on the short cap. It doesn't really affect the view at all, and it will make direction of your clip and ability to manipulate the mucosa to some degree much easier. Again, that's schematically represented here, and that's first choice to try and control the bleeding. If you can see the bleeding vessel, the bleeding point in the diverticulum, then put a clip on it and it will work well. Equally well, the monopolar will work well there too. Again, if you see it coming from a narrow neck diverticulum, then you can use a clip again. This time you're going to try and clip the whole diverticulum shut. And again, there are a variety of different clips on the market. Make sure you've got the one that's long enough to go down your colonoscope. The wider they are, the better. The shorter the stem, the better. And the ability to rotate them through 360 degrees is a huge asset. So again, know your clips, know your release mechanisms, and know that your nurse will release them effectively when you give her the command to do so. So that's the clip story. And again, you can see here how you can apply them across the diverticulum to try and control the bleeding, tamponade it within the diverticulum itself. And then there's the last way you can do it. And here you can see there's a cap on here. But if you can put that cap on, again, obviously, one of the things is that you're not going to go in there with a bander. You have to actually come out again. So the simplest thing to do is to place, if you think the best solution is a EBL, then you should put a clip beside where you've identified the bleeding so that you can't miss it when you come back and you realize which diverticulum it is. It's usually only one that's bleeding. So again, this is essentially what you can do with the Banda, and you can apply it and suck the diverticulum into it. And it should look something like this. It actually looks really like a polyp, but it is actually an inverted diverticulum. And then there's the real JAWS version. And the OTC clips come in different varieties. And in diverticula especially, you're actually dealing with soft tissue. So there is one that doesn't have this sort of, it has more rounded nodules as part of the actual clamp or snare. And those, again, you need to have in your armamentarium. Whoopsie. And there are a variety of different devices that you can use, and there's a grasping device, again, which helps to pull the diverticulum into the clip device, so that you can deploy the over the scope clip. And this is what it looks like. It's quite a weapon, and again, you obviously don't want to have this on when you're looking. You will have to go and come back. And I think Adam alluded to the use of this when he talked about post-polypectomy bleeding, because this is a very good way of stopping that type of bleeding as well, especially if it's serious bleeding. So this is a recent article that's looking at these methods of endotherapy. As you can see from the big series in NHS, this group of patients are not very common. And you can see the series here varies from 2 to 6 to 1 up to large numbers in 2 Japanese series where they've been looking at EBL. And again, a variety of different techniques have been used. Generally speaking, it seems that most of them are effective in the short run, but then there's a very variable percentage who will, in fact, get recurrent bleeding during that same admission. So you don't know whether it's the natural history of the bleeding or whether it's actually the intervention itself. So there you can see some people are using the hemostatic powder. Again, I think that's not a great idea, and I'm not at all sure how efficacious it is in the colon. And again, this shows that even the OTC is not being used frequently. Most of the comparators here are either injection, clipping, or band ligation. So that's what information is available from these studies. Really, the more recent ones with these larger numbers, again, suggesting you can have initial success, but a bit unclear how lasting it is for all the patients. So my take-home messages from the endotherapy aspect of lower GI bleeding are that these are very rare events. You should have good bowel preparation. You should know your tools and have them all available, because you're never quite sure which one will be best for the job. You know that they're all of sufficient length to go through your colonoscope. And again, just be very careful with energy sources when you're using them in the colon. Some parts of it are thin, and these diverticula, remember, have no muscle to cushion you from perforation. So use monopolar or clips. They're fairly safe, as are the EBL. So with that, I'd like to end my share here and take any questions about this section.
Thanks, Sandie, for excellent and clear overview. I don't see any questions. So, I mean, your initial algorithm clearly separates patients who are stable from those who are unstable. And if those are unstable, CT angio seems to be the hallmark procedure. But what happens if you don't have CT angio accessible?
I think, again, sort of, these patients are quite rare, so you have to decide what you have in your toolbox locally. And many of these patients will present to the surgeons. And so again, it may be that you're going to have to operate on that patient. So there are a few options that you can go to then. One is, can you get the patient stable enough to be able to do a colonoscopy on the patient? And maybe the best place to do that colonoscopy is in the operating theatre, so that you can proceed if you can identify a localized source that you can't deal with, or that you have to realize that you may have to operate on the patient without knowing the source. And again, that's why even a CT scan is important to try and rule out a small bowel cause. And we recently had a patient who had 4 colonoscopies for what was thought was diverticular disease, for serious bleeding. But what turned out to be the case was that when he was actively bleeding on the last occasion, you could see that the blood was not coming from the diverticulum, but it was actually coming from the small bowel, because when you intubated the terminal ileum at colonoscopy, you could see there was still blood coming from above. So I think if you can use your colonoscope, if you can have time to put a nasogastric tube down and give bowel prep, you may be, it may help you to guide your treatment and resort to surgery that might be of a lesser significance than taking out the whole colon.
Excellent. There's some questions from Acque before, and Acque, if you'd like to unmute and put on your video while you're doing it. Sandie, a commonly asked concern is, or question is, safety of prepping a colon during an active lower GI bleed.
Yes. Again, I think it comes back to which of the patients will actually stabilize. And if they stabilize, I think you should be able to do that. But often, unfortunately, these patients are frail. And again, you must sort of weigh that into your armamentarium about what they are actually fit for. But I think trying to do it when there's stool and blood around is a recipe for really not being able to do it. And again, you may be again, if you're going to theatre, you may be able to manipulate the colonoscope intraoperatively to help guide where it's coming from. So I think there are factors that will lead you to the right decision making. And again, these are very high risk patients if they come to surgery, because usually they have comorbidities.
Okay, Acque is unable to ask the questions herself. So hello and welcome, Acque. So I'll ask them on your behalf, and I think you can see them, Sandie. There are a number, but interesting. How often do you use the scoring system for patient care? So again, sort of, this has evolved because people have looked at it as a specific entity. But the other scoring systems, it's very similar to the Blatchford. The only real difference is that the hemoglobin is good. And I think it's a good triage tool to not get your inpatient system bogged up with patients who can be safely managed as an outpatient, to be honest. I think that's where its value is. I don't think it's in any real value in triaging your patients who are seriously ill or predicting which ones are not going to make it. And presumably those that you discharge because of a good score, you will follow up with an elective colonoscopy to determine the cause. Yes, of course. And you can, again, there's no real hard and fast guidelines as to how that, what the time frame for it is. Again, one of the problems that you don't see infrequently is patients who have got poor anticoagulant control. And these newer groups of patients who are on the newer anticoagulants are at increased risk from GI bleed. So again, they're another group of patients who require to be colonoscoped to exclude that you haven't unmasked a lesion in the colon. Again, you want to wait and optimize their anticoagulation before you do your colonoscope. And then there's some questions on hematochezia, performing a colonoscopy on an unprepped colon for hematochezia.
Again, if you've got good irrigation and it's purely blood that's coming, you may be able to get past it. But hematochezia usually means that they're bleeding at 1 ml a minute. So that's fairly impressive. Again, if there's any stool around, if the blood hasn't created a stool cleansing, then it's blinking difficult to see anything in that circumstances. And again, fortunately, these incidents are rare. The individual, even experienced people, have not seen these entities very often, and they're applying hemostatic techniques that they're using in other settings more frequently, or for different reasons, even for perforation with the OTC. So it's a question of get somebody experienced who's experienced with endotherapy, because they won't necessarily even be experienced with this type of endotherapy.
And should you proceed with repeating colonoscopies in patients with hematochezia or go straight to CT angio?
Again, I think we haven't touched on obscure GI bleeding, but when it becomes obscure, and one of the problems is that diverticular disease is phenomenally common when you get into the over 60s. And so the mere presence of diverticula don't necessarily mean that that's the source. So I think it's a reasonably good thing to do, at least to do a CT, because that will detect masses. And again, we've recently had a gist in the small bowel, the same case I told you about, that was masquerading as bleeding diverticular disease in a 55-year-old. Took a long time, 6 colonoscopies to make the diagnosis, and the CT showed the mass.
Anakri asks about going straight to surgery if you have no accessories in your toolbox, but I think you've answered that by the the stability or instability of the patient, and the fact that you should be reluctant to go because the mortality is so high. Would you like to add anything?
Yes, no, I think that there is a place there for if you have lack of resources. Again, if you have a colonoscope, you may be able to guide that on table to help you localize the degree of surgery that you have to do. But I think if you don't have any endotherapy options and you don't have any embolotherapy options, then theatre is where you're going to be, and that's the best place for the patient, because if they are shocked, you can continue the resuscitation while you're doing your operation.
All right, I don't see any other questions. Would you like to proceed with your case presentation, Sandie?
I can do that. Hopefully it will be a little fun and it will be a bit shorter.
Okay, it's a presentation of an acute abdomen with a left-sided cause, I believe.
Indeed.
Thanks for all your questions.
Are you seeing my?
Yeah.
Doesn't look.
Well, it's not. I don't know if it is in presentation.
No, let me just share this again. I seem to. Have you got it?
I don't know if it's in presentation mode. That's it. Yeah.
Oh, you can see it now.
Yeah. Perfect.
Okay, so this is a patient. It's rather has a surgical orientation, but I think it would be good fun for the physicians to speak to it as well. So this is about a 62-year-old overweight diabetic male who presented in February of this year with an alteration in bowel habit and episodes of fever who presented to casualty. He was obviously not seriously ill, but he was referred to SOPD, and he turned up there 2 weeks later. He was assessed as having diverticulitis, or a non-benign colon lesion. He was tender in the LIF, and investigations were booked in terms of blood work and also for a colonoscopy. But the waiting list for the colonoscopy was a little bit away, and I'm not entirely sure that that was the investigation of choice. And he presented on the 2nd of March, at 10 p.m. in the evening, with an acute, generally what was considered an acute abdomen. He was generally tender, he had a tachycardia, his systolic blood pressure was 95, and his bloods showed, the only abnormality his blood shows were the white cell count of 24,000. His U&E and his ABG were all normal. So I would like to just ask the audience what they would do. Even if you're a physician, you can please answer this. And if you could just vote if you're there, just for the fun of it. So it's, are you going to take this to the theatre now in the middle of the night? That's what the registrar wanted to do. But, or do you want to resuscitate the patient, perform a CT scan and plan surgery for the next day? Would you like to vote if anybody's in the voting mood?
It's not allowing us to vote, Sandie.
Cheryl, can you fix that? Or
that's better, thank
Can
you.
you see it now? Okay.
Yeah, thank you.
you could end the poll now.
Okay.
It looks like everybody wants to wait. That's probably what would be recommended almost everywhere these days. Operating on overweight diabetics in the middle of the night, even if they are peritonitic, it's probably best that you resuscitate if they respond well to resuscitation and investigate the patient. So I'm pleased to see that probably most of the audience is physicians and not trigger happy surgeons, but ideally you want to do that. If you could stop sharing the poll. I can do that, I think, as well. And you can, let me see if I can close the poll. Can you share the results?
Okay, let's do that. I'm just,
Okay.
Can I
So
stop it?
yes, you can stop the share now.
And I'm closing it. Is it gone?
Not yet, but I think I'm also in the. Okay.
Right, we've got an extra CAT scan.
Yes, I'm just trying to actually get rid of this thing. Sorry. So this was the CAT scan. So I have another question for you. This is one picture of it, and this is another picture of it. This is what we found. I'll go back to the previous picture. Again, you can hopefully see the abnormality which is sitting here, and you can see these little bits and pieces here. And then you can see whatever it is there with a little bit of gas there. So again, what is the likely diagnosis? If we could run the next poll.
Can you see that?
Yeah.
Okay.
If you could vote again.
Okay.
That sounds like we've got whoever's there. So looks like the if you can share the
They're on.
It is
there
on.
you, okay. So you can see 62% think diverticulitis, a 23% colon cancer, and the appendiceal mass is a reluctant third, but nevertheless, I would think it's still in the equation. And nobody voted for a bladder tumor. If we can stop sharing.
Okay. Yeah.
And close it. So we decided now to operate on the patient, and we found a densely adherent mass to the dome of the bladder, and it was adherent to the lateral portion of the abdominal anterior wall. There was pus all over the peritoneal cavity. It wasn't particularly smelly pus. It was thin pus, but it was definitely generalized peritonitis with a little bit of exudate. There's no obvious free perforation at the colon, but it was obviously inflamed, and there was no fecal contamination. But when we palpated the liver, we found that there were what felt like surface metastases on both surfaces of the liver, suggesting that this probably was a cancer. So this gets very surgical now, but I'd be interested to see exactly what the physicians in the audience know about it. But what are your options and what do you want to do? These are confirming the metastatic disease, which was actually on the CT, that wasn't picked up before the operation. And you can see here again. And in fact, at palpation, there was probably at least 8 palpable lesions that we could feel. So these are the options. If you could just put the poll up.
It's coming.
That's grand. So please let me know what you think we should do. If you don't understand these terms, I will eventually explain them to you. There's obviously not sure how many, even the physicians, please have a go at this. It will refresh your surgical knowledge. Even you, Chris, if you remember what some of these things are. We can even do a history lesson on Hartman. But obviously there are a few people here who have some ideas, which is very refreshing. It's nice to know, definitely nice to know. If you could end the poll and just share it. Okay. So you can see that radical resection in Hartman was probably the most popular choice, and some people are voting for a stoma and washout. The correct answer is, there is no correct answer here. And I presented this at the Fellows Weekend. Maybe some of the fellows are here amongst a specialist selection of trainee colorectal surgeons and some experienced colorectal surgeons. And I'll tell you what the consensus was. If we can share the results, please.
Oh, we did.
Oh, we did.
We did. Okay, let me just close. So, yeah, we've shared them again. Let me close it. So these are the options. You could either take out the stoma and wash it out, and that's very particularly popular now to some extent for diverticular disease when there is no gross fecal contamination and without very, very severe peritonitis. So that's one option. We didn't like that option because we felt we should remove the source, even though we couldn't see an actual macroscopic hole. we believed it was the source of the microperforation. Then the Hartmann's procedure is we remove the lesion itself, take out an end stoma and close the rectal stump. And that is in fact the operation that we did do. Or we could hook the patient up and what we do call restore continuity. Again, we could place an ileostomy or a proximal colostomy as the defunctioning options, and you could argue about them. Obviously, the metastatic disease is another problem, but this is what the specimen showed. And we actually didn't do a radical resection. We felt a 62-year-old who had diabetes and was overweight, that the peritonitis itself, even though he was reasonably stable and under the anesthetic, was not something that we would consider doing an anastomosis, and that we didn't really want to prolong the operation with extensive mobilization of the colon to do what you would consider to be a radical operation. So that was the tumor. It was T3. It's probably T4 in actual fact. And we obviously knew that he had metastatic disease now. And there was one lymph node positive on microscopic. And these are the features that they look for, which are very important in terms of whether this patient has microsatellite instability and might be worth investigating some of his relatives. And again, we just used these factors. Again, they may influence the degree of and the type of chemotherapy that might be required. And as I said, that's what we did. That was the operation that we did. And we actually took, we didn't have to take a piece of the bladder, but we did have to take a piece of the anterior abdominal wall just to make sure that we didn't leave any macroscopic tumor or tumor related to the margins. So these are the things that we're left with. He's a 62-year-old now. What is his prognosis? And I'll show you a little bit about that. Should he have chemotherapy? And will he have reversal of his Hartmann's, i.e., can we go back at a later stage and get rid of his stoma? There was some consensus that we could have considered just defunctioning him and assessing him further with a view to seeing exactly what was happening, and that we could have deferred doing the resection, but the majority was in favor of doing the type of operation, the Hartmann's procedure that we did do. This is some information about perforated colon. So about less than 2 to 5% of the presentation of colon cancer is with perforation. And it can either perforate, at the site of the cancer, or if the ileocecal valve is closed, what happens is that they perforate at the cecum because it becomes a closed loop obstruction. And in fact, I used to think that was the commonest source of perforation, but indeed it's actually at the site of cancer, as you can see from this. And again, you can see the types of operative mortality vary quite considerably from 62%, but they're certainly sitting usually round about 20 to 30%. So your prognosis is directly affected by your ability to survive the operation as much as it is by the extent of the cancer. And again, this is looking at series from early on, from 74 to 1996. And you can see here again that the perioperative mortality looks a little bit less as you get into the 90s, but it's still sitting with these sort of 20 to 30% figures. And if you look a little bit later, you would think with ICU and other things, as you come into the early 2000s, there's still a significant perioperative morbidity. So now it seems that it's the rule for it to be under 20%. And again, the question is what happens to it in terms of prognosis. Well, in terms of prognosis, there was a nice study that looked at two groups of patients, one presenting with obstruction and one presenting with perforation and one with obstruction. And you can see that these are basically advanced tumors, and that they have a very high distant metastatic rate, and that rate is higher in the perforation group than it is in the obstructed group. And again, you can see local recurrence is higher here, because often these patients have transperitoneal spread. Our patient didn't have that. And you can see that two-stage operative rate was only 20%. And we thought that would be higher, but for obstruction, it's about 50%. So that's the sort of prognosis that you're looking at. And you can see here that the prognosis is poorer for perforation than for obstruction, and that essentially these cancers are really at advanced stage when they present, and if they have metastatic disease, again. But if they survive the operation, these figures are not really that much different from the same stage if they had an elective resection for the same stage. So our take-home message from this case is, which we thought was interesting, and again, there's no right and wrong answer, but you should tailor the surgery to the physiological condition of the patient. You should consider a radical resection of the primary. Hartmann's is the common solution, and it's what most people would do. So there are the options of even a stoma and of restoring continuity if the patient factors were favorable. And the survival curve is that of an advanced stage cancer if you survive the operation, but there is a high mortality. And generally speaking, that's the sort of take-home messages from this case. So I hope you enjoyed your journey into surgery, and that you're a little bit wiser about how colon cancer can present and how it can be a mimic of diverticular disease. Thank you.
Thanks very much, Sandie. Excellent clinical presentations, really, which is what Gecko is all about, to give you these clinical pearls that you really seldom find. So thank you very much. I really appreciate that. Are there any final comments or questions? Sandie, any way you can differentiate colon cancer perf from diverticular perf clinically? Obviously, in the acute perforation setting, impossible, but pre-perforation?
Yes, well, I think if he came into the state system here, so that's and there's an obvious delay in how he could or should have been investigated. But I think if you'd done the CT scan, it would have been the preferred investigation if he'd been in a more, shall we say, efficient healthcare system. And I think you would have made the diagnosis of a colon cancer then, prior to it perforating. And again, at that stage, you would have almost certainly been able to do a colonoscopy. But obviously the month delay pushed him from, he probably had a very advanced cancer anyway, pushed him into that micro perforation and resulted in events overtaking him. So yes, I think very, very difficult in patients with diverticulitis, because that's much, much commoner. And again, I think the take-home message if you're doing colonoscopy on diverticulitis is to wait. There's no rush in diagnosing the cancer. Usually it's not associated with the type of mass that you saw here. So, and then you should always exclude there being a cancer in that group of patients, particularly if there looks as though there may be some stricturing of the colon. And in that circumstance, again, it's a high-risk colonoscopy in terms of maneuvering it and getting through it. So you should have a low index of using a gastroscope if you're having difficulty, or a pediatric colonoscope. And I know some people are very, very keen on using water immersion colonoscopy, particularly for negotiating the sigmoid safely, because I think it can be really quite scary to get through the segment, and that's obviously what you want to do. And it's largely usually just a left-sided stricture, and again, the gastroscope will almost certainly get you through it if you're having difficulty with the colonoscope. So that would be my take on your approach to diverticulitis. Delay until the inflammation settles down and do the colonoscopy.
Excellent. Well, thank you, Sandie. It's 5:30, so that concludes this week's session. Thank you, Cheryl and Karen in the Gecko team for sorting out all our logistics. And also thanks to the ECHO team at University of New Mexico and in India, and also the foundation. Please fill in the feedback forms which are available on the chat site. Recordings are available on our Gastro Foundation website, thanks to our sponsors. And we look forward to welcoming you back next week. The session will be devoted again to hepatocellular carcinoma, chaired by Mark Vernon, and there's some interesting topics to discuss together with some case presentations. So thank you very much to all of you for attending and for your interest, and good afternoon. And again, thank you very much, Sandie.